I see some returning. Welcome back. Thank you, Anna. Hi, Grace. Nice to see you. Hi, Esmeralda. Emily and Anne are returning. Hi, Laura. Hi, Hannah. Good. Emily's on. Liliana. Shaway. Perfect.
Everybody, sorry having computer issues, but I think I'm here now.
Good. Yeah, we can hear you. Greg, I'm going to
Okay.
make you a co-host as well.
Okay.
So I will go through, I'll get us started so that we have enough time for our speaker and for discussion. And as we're going through our introduction slides, please feel free to sign in. We are so excited to kick off our new UC San Diego implementation science seminar. You guys will see that we kind of changed the name because now we are co-hosted by all three. We have the DISC, we have INSEP Center, and the HIV Implementation Science Hub. So for the sake of a somewhat shorter name, but Greg actually pointed out in one of our meetings that there's about the same amount of syllables as if we had all of the centers' names in the title. So um, bear with us. But we are so excited today to have our visiting scholar, Dr. Lijing Yan, present on improving primary care based stroke management in rural China, a hybrid type 2 effectiveness implementation trial. And before we introduce our speaker, I do have just a few announcements, some events that are coming up, and I will put all of the links to these events in the chat. So don't worry about trying to grab the URL or the code as I'm going through. So first is with our colleagues with the NISA and NACURA African Partnership Initiative. There is a monthly webinar series for research administrators. And the January session will be on identifying and assessing funding opportunities, navigating NIH and other sponsors funding mechanism. Next, we have the Visiting Scholars in HIV Implementation Science program. So they've actually extended the application deadline to Monday, January 19th. And this is a great opportunity for anyone who is interested in working with the Cheshire Network and our implementation science hubs to receive tailored mentorship and virtual in-person networking opportunities and different educational opportunities as well. I will say our February Adaptation, Fidelity, and Tailoring Work Group meeting is going to be on February 9th. We will have Dr. Monica Perez Hoyas, and she is going to be presenting on the new Functions and Forms repository from the Functions and Forms web tool. I would say this is a very hot topic across the D&I conference and at our January work group meeting. So we're very excited to have Dr. Perez Hoyas present on this early on this year. And then the we have the 2026 Conference on Intervention Optimization. This is co-hosted by the Center for Advancement and Dissemination of Intervention Optimization and the D3 Center. Registration is open, and I will put all of these links in the chat. This will be in May, so that will be a very interesting conference. And then one last update before we introduce Dr. Yan. We just want to highlight a recent publication from the INSTEP team. Dr. Alvin Stammer and Lauren Berkman-Frazee and their colleagues wrote this recently published paper on understanding the mechanisms of multi-level implementation strategies for autism interventions in a randomized trial across the service systems. So we will put the DOI and the link for that paper in the chat as well. And so now I will hand it over to Greg to introduce our speaker.
Yeah, thanks, Kara. Thanks for covering all the many things that are happening around implementation science these days. So it's my great pleasure to present Professor Lijing Yan, who is a visiting scholar with us here at UCSD. Fortunate to have her on board. Dr. Yan is a professor of global health and director of the Ironman Lab at Duke Kunshan University, China. Also adjunct professor at Duke University, the US, Northwestern University, Peking University, and Wuhan University. That's a lot of academic silos to be involved in, and actually a lot of those work together across areas. Dr. Yan's main areas of research are in primary care and community-based cardiometabolic disease prevention, healthy aging, digital health, and big data innovation and implementation science. She's PI or co-I on over 20 US NIH, United Kingdom or MRC or China-funded grants totaling over $10 million US. She's published over 200 peer-reviewed papers with Google Scholar Index, H-index of 64, I-index of 143, and in the top 2% of scientists. She's also associate editor for Implementation Science and for the Chinese Preventive Medicine Journal, and on the International Advisory Board, member of JACC and Lancet Global Health. And I think importantly and recently also co-organizer of the Asian Conference on Implementation Science, which was recently held in Guangzhou, China. And some of us were fortunate to attend that conference, which was very successful, and working to advance implementation science in China and beyond. So with that, I turn it over to Dr. Yan.
Thank you so much. Thank you, Dr. Aaron. Thank you, Kara. It's such a great honor for me to share what we have been doing as a team with lots of collaborators and stakeholders with you. As discussed, I will use up to 35 minutes and hopefully have some chance for discussion. I will share my slides and the slides, I prepare a lot of slides and they should be, and I can share them with you all as well. I hope you can see the full screen now. And as I said, I have lots of slides, but I will go over some of them very quickly or even skip a few. They are ready, and the papers, also I have a list of papers that you can refer to for this study. Before I get to the study, I want to show you this figure. It's sort of like a table figure that I find for ACTRI that most of you know about, which is the Altman Clinical and Translational Research Institute, where DISC is a part, and we can see these dots indicates the level of engagement at the different translations, like T0 is basic science, transition to humans T1. transition to patients T2, transition to practice T3, transition to community T4. So DISC has the 2 dots and the 3 dots here. I would say that I have about a 15-year journey starting from 2009 or to 2010, going from translational research, which I call common sense because I didn't have a lot of rigorous methods to rely on until more recently in 2017 or 18 that I started knowing and learning about implementation science. So I still consider myself a learner. This is the 10-minute talk that I give in the Asian Conference on Implementation Science that we had the honor of having Dr. Ahrens and others to support. And but I'm not going into this. I will focus on today of one study we did, which is actually part of a series of studies that we built on earlier studies that I won't show. So you can see this study is a bit complex, but we do have from 2009 until 2017 that this study started officially. So that would be about 8-9 years of previous research that we're building on. So I will use the PETALS framework, which many of you have not heard about. This is proposed by Dr. Roman Xu, who I co-lead the Asian Asian Conference on Implementation Science and also co-lead the capacity building for China on implementation science. Then I will briefly talk about the EPIS, which many of you know very well already. That is established by Professor Ahrens. And then I will spend a bit time on the evaluation. So what is this acronym about? I will show you later. So this is a secret for now for you to, it's like a hook for now. So the paddles originally proposed by Roman Xu that we are working to refine this. It's a framework showing the process of implementation research, starting from a problem, a real-world problem, and identifying evidence-based practices, the E, and the determinants, which are really barriers and facilitators, and the action are the strategies to use the A, and the long-term sustainment. That's the L, and the S, so it's PEDOS. The S is designed to be small and plural, referring to evaluation and possibly scaling up. And then it goes iteratively, so this rhymes with the PEDOS. So for our research, the problem is the big burden of stroke in both urban and rural China, but especially a rising problem for rural China, the red lines, which is higher than urban China already. So this is the global burden of disease square pie chart that many of you may be familiar with. This is for China, and stroke is the #1 burden, and it's about 1 in 5 deaths was due to stroke, according to recent data. And the #2, shortly after, is the ischemic heart disease, is about 19%. And also, it is a serious problem. It can be fatal on first occurrence. So this is the 28-day mortality after first stroke based on the 500,000 China Coronary Bank. These are the 45,000 that has confirmed stroke through imaging. And you can see this is hemorrhagic. And then we have SAH and ischemic stroke. The hemorrhagic stroke is particularly fatal early on. The 28-day mortality rate overall is 11%, but for hemorrhagic stroke, it can be anywhere from 28 to 60%. Over half of those older stroke patients would die after 20 days, within 20 days. So prevention is really important, including primary prevention and secondary prevention, which is what we focus on. So this is the 5-year stroke recurrence and mortality rate. On the left is recurrent. Overall, in 5 years, 41% of recurrence, 17% total mortality after 28 days. So secondary prevention is also very important. We have lots of evidence-based practices in the form of clinical guidelines. What I show here in Chinese is the clinical guideline for grassroots levels designed for primary care settings, but they're still very complex, and the implementation of these guidelines is poor, especially in rural China. So we have very large disease burden, lots of patients, and there's a need for lifelong prevention, both primary and secondary, but a huge lack of specialists, such as neurologists in China, both urban and especially rural. So there is a strong case for shifting and sharing the tasks, usually by specialists with the primary care. And in China, we have a long tradition of barefoot doctors who mainly work on maternal and child health, such as vaccination, etc. And it contributed to the huge reduction in maternal and child mortality and increase in life expectancy. But where we find out that these barefoot doctors, later they're called village doctors, these are the primary care providers in China. They usually are not well equipped to manage chronic conditions. So that's where we come in, and we would like to come up with a suitable, effective strategy to support them to do that in their communities. We chose to work in one province where the stroke burden is high. This province is Hebei, and in one county called Nanhe County. And in Nanhe County, there are 8 townships. And we chose 5 townships, these 5 dots, to work in. And the total population for this county was 360,000, 8 townships, 218 villages. We work in 5 townships and 10 villages in each township, and a total of 50 villages as our clusters. So this is one photo we took from our site visits. She was 60 years old, has a stroke 5 years ago, and taking multiple regimens, and she could not read. So she really needs more more of support from her families, from her primary providers. So in order for us to identify the major barriers and facilitators, we did a lot of field-based research, and then identified multi-level barriers that is at the stroke patient level, village doctor level, specialist level, and system level, etc. So skipping over the details of it, many of these are common, shared in maybe remote areas in the US as well. This is the 3-tier healthcare delivery system in the county hospital, township healthcare centers, and village clinics managed by the township healthcare centers. So we use the core functions and core forms to identify the standardized functions and tailor to our specific context. And also for the whole intervention design, we draw heavily on the chronic care model, where the interactions between the, in our case, is not really a team, but the village doctor with the patient. We hope they can become more informed and activated. This is the center of our intervention design. We also have decision support, and delivery system support and self-management support. So this is on the village doctor side. We provide training for them using the train the trainers model, and then they will provide monthly follow-up because these are stroke patients. So we believe the monthly follow-up is warranted instead of bi-monthly or quarterly. And we have the WeChat group providing support for the village doctors and performance-based financial incentives. For the patient-facing side, the core function we identified as being improving. This is a very busy slide, but is to improve their medication adherence as well as physical activity, through education and the monthly follow-up with the village doctors. And the education was done through the voice messages recorded in the local dialect. So again, this is a busy slide, but if you could look at this figure, we have the village doctors supported by the system. So this is the acronym, system integrated. So the specialists in Tiantan Hospital in Beijing supports the county neurologists who train the township physicians and the village doctors. And the mobile health technology comes in to have the smartphone-based app for the village doctors, but the patients have feature phones. Some of them share a phone with their spouse. So many of them could not read, so we give them the daily voice messages, which is sent out for free automatically once they agree to have their number entered. So skipping over these details, and we did this pilot in 4 villages to test out our intervention. This is in Chinese because this is the monthly handout in paper form to the patients, and we try to put in the icons for when to take the medicine, emphasizing medication adherence and physical activity, setting goals for both, and also give them the phone reminders. The phone number would be a sticker in here, so they don't mistaken those phone numbers to be like junk phone calls. This is the mobile application, Android based, because no village doctors was using an Apple phone. Most of them used Android based smartphones. It has multifunctions. As I said, we built on previous research to develop these functions, but it's using a user-centered design, so a very easy interface that we learned from WeChat, which is the popular social media app that we all use. And so it's easy to use on the user end, but it's powerful as the backend functions. And this is what it looks like. So the patients received only the phone message. The county doctors can manage the county level performance, and the township can see what's in their township, and the village doctors can see all the details for their own patients. And this is the development of the daily voice messages, mainly based on the health belief model, because we would like this to be a way of changing their behavior. So each message has 3 parts. We start with a reminder, have you taken your medicine today? Or alternatively, every other day, do you remember to do physical activity today? And we gave them some information and specific tips to support them. So in summary, this is a complex health intervention that is multi-component. The core functions are task shifting, task sharing, provider-patient interactions, and empowerment of the implementers and patients. The evidence-based practices we're promoting are the regular follow-up, medication prescription, and adherence, as well as physical activity. The implementation strategies are provider training and support, provider incentives, both economical and non-economical, which are awards, government recognition, etc. And we provide the technology as a one way to help the providers and the patients. In terms of the long-term evaluation, one of my doctoral students did this work. So we landed on this public health program capacity for sustainability framework to do the interviews. And the design principle was back in the 2016-17, and these long-term sustainability was done after COVID in 2023 and 2024. So the 4 phases of the study really mapped out well to EPIS. So you can see we have the formative research from beginning in 2016 until earlier in the trial. So after these earlier study And the pilot study, we had a 1-year intervention from summer of 2017 to summer of 2018. And then we did more process evaluation. After COVID, we had a long-term observational follow-up. So these can be considered the summative research. So according to EPIS, it would be the exploration, preparation, implementation, and sustainment phase. So these are the details of what we did in each of the phases, and how these things are working together. I said it's retrospectively because I wish I knew Professor Ahrens back then. So we were mapping this out to our study retrospectively. And if we had known APIS more, I think in terms of each phase, we would have more rigorous guidance from the APIS tools. Which I have learned and been using in our current study, which for this one is in urban China. So I will use the rest of about, I would say, 10 to 15 minutes to focus on evaluation of this study. We call this cinema intervention that included both the EBPs and the intervention and the implementation strategies as a bundle. So our key question is, can the primary healthcare providers, who are the village doctors in rural China, supported by the system, which is the system integration, and equipped by digital health technology, so that's the cinema model, can they provide essential evidence-based care, which is the implementation outcome, and reduce systolic blood pressure. So that's the main primary outcome for clinical outcome for the trial, for the 1-year trial. So as many of you are familiar, this is a hybrid design. So we are evaluating both the effectiveness and the implementation with equal focus. So this is a HYPE-2 trial. And as you know from Dr. Curran and others' paper, the HYPE-2 trial has these equal aim and equal research questions, so co-primary outcomes as well. It needs to pay attention to both patient level and multi-system level. I put this big thing over here because a hybrid type 2 can be complex, and we need expertise from both sides, effectiveness and implementation, and both quantity and quality, etc. And there is this interesting footnote in there in the grant application. Even if it's a hybrid type 2, it may not be identified as such, depending on where you are submitting your grant to. So according to that paper, there are conditions for use of hybrid type 2, such as strong phase validity, a strong case of indirect evidence, minimal risk, there is the momentum, and it's supported by stakeholders, and there is need to gather more data. So the ideal condition is to have reasonably close evidence from previous research in similar settings, and it's not overly complex. So we believe our study fulfills that. And we have previous research such as this one that's conducted in rural China as well among village doctors. So there is high face fertility, strong indirect evidence, and very low implementation risk. No new drugs, no new measures beyond village doctors' capacity. In that time, when we were beginning to do the study, there is strong momentum from the government of the healthcare reform to strengthen primary care and to shift tasks to primary care. So we received institutional support, and there is equipoise to gather more data. In terms of the logic model that you're familiar with, it maps out to our study as multiple inputs and different levels of the intervention for the system, village doctor, and stroke patients. We have the outputs, immediate outputs, and midterm outcomes listed, which I'll expand on a little bit, and the long-term ones, which fortunately we are also able to see. So for the trial design, this is the flow chart according to our power calculation, 25 patients from each cluster. So we have 50 villages in each cluster, and they are randomized half and half to 25 in the control, 25 clusters in the intervention. This is the calculated sample size at the patient level, the inclusion and exclusion criteria. So for the process evaluation, we mainly learned from the MRC process evaluation framework for CHI, complex health intervention, and the REAIM framework. Skipping over the details about the REAIM. So again, this is a summary of the outcomes on the implementation side and the effectiveness side. Due to the interest of time, I will only show you fidelity, systolic blood pressure, and long-term mortality outcome. So this is details of the data collection and methods. For the fidelity, we have reasonable fidelity for the village doctor for participation in the training. The monthly follow-up conducted by the village doctors on average is this many during the whole intervention, and they send out 37 villages. This is the message in the WeChat group of their engagement. In terms of the patient, they most of them went to 12 monthly visits, 11.5% received less than 12. And for the voice messages, this is the mean number they received, and 28% didn't receive more than half of the daily voice messages, because the way it is that from 7 to 8 a.m., that's we find out where they were together, if they have shared cell phone. So we call them, they usually are early risers. From 7 to 8 a.m. 3 times. If they didn't pick up after 3 calls, then it's considered over for the day. These are some summary of the qualitative process evaluation that I'm not banking on. So this is the actual flow chart. We did it in 50 villages. Instead of 1250, we had 1299 patients in the 2 groups. And we have very small number of deaths or lost to follow-up. So this is the 1 year follow-up number of patients. We were able to find out more of them, even if they didn't participate in the 1 year follow-up. And then we follow them up for 5.5 years until 2024. So for systolic blood pressure, you can see we have the gray 1 year timeline, 12 months from summer 2017 to summer 2018. It's the active intervention period. I want to emphasize that after that 1 year, we did not have any active intervention going on, whether on the EBP side or the implementation strategy side. You can see both control group and the intervention group had significant reduction in the systolic blood pressure. The difference was significant, even though the magnitude was only about 3 millimeter mercury. But it's cumulative over time that this difference was capped. And in the 5-year follow-up, this difference was still significant at the 0.05 level. I will keep it. I won't go into the details of why the control group had such reduction, and we can discuss that later if you're interested. This is the busy table of subgroup analyses. You can see there is a stronger impact of the intervention for women, as well as for lower income folks, and for lower educated people. So even though we've done our study in rural China, trying to reduce disparities between urban and rural, even within rural China, our intervention benefit those who were more vulnerable people, of women, lower income, lower educated. The most encouraging result for the long term was that even if when the intervention didn't continue, the active intervention didn't continue, we see that there is this early, even starting from the 2nd year, 3rd year, significant difference between all-cause mortality. This is the cumulative incidence for the control group, blue one on top. For death, and relative risk reduction was 27%. For cardiovascular deaths, also 27%. For stroke deaths, 29% reduction. over 6 years. So we did also cost effectiveness analysis, because skipping over the details, basically this is to say within trial, um, for per unit systolic blood pressure reduction, the cost, the incremental cost, in fact, the ratio was $8.8. So it's highly cost effective for per QALY gained, which is quality adjusted life years gained, is over $800. So it's highly cost effective because this is the willingness to pay threshold of one and a half national GDP, which is over $23,000. So of all the 1,000 bootstrap simulation we did, it all fell below the willingness to pay curve. For the post-trial, we had our own data to rely on. It's also highly cost effective. So these are the papers. The green ones are the design papers and statistical analysis, digital health development paper, text messaging development paper. And these are the current sample selected result paper, 1 year trial result process evaluation, observational follow-up on blood pressure and functioning. This is mortality, this is economic evaluation. We have a few others digging into more of the mechanisms and the cumulative blood pressure effect, or the component specific analysis that we're doing under the guidance of Professor Donna Spiegelman from Yale. Those are work in progress. So coming toward the end of my sharing, this is what I learned through nearly 15 years of doing pragmatic trials, that we've got to keep the content simple, because we're dealing with very complex health interventions. So really need to keep the content of the intervention as simple as possible, tailored to the context. And this acronym for English speakers, native speakers, you probably know, I need to remind myself time and time again to keep it simple. Otherwise, I would be stupid. This process needs to be slim and streamlined, not too complex, and to rely on smart approaches, and to, from the very beginning, to have scalability and accessibility in mind. I find that policy is important for scaling up the intervention, and leadership for the sustainability. This is only a partial list of our collaborators, and this is not just for this one study, but for our series of studies. For example, this is our partner for the APP development from China Mobile, etc. So this is my email, and also my QR code for the LinkedIn. First name dot last name at Duke edu. So I would really welcome the chance to be in touch, and also to have some discussion of this study that I shared very quickly. Thank you.
Thank you, Dr. Yan. I'm going to pass it over to Greg for the discussion portion.
Yeah, thank you, Dr. Yan. I just want to open it up for questions from everyone, but this is impressive. And also thinking about the scope and scale of China, I was just thinking back to that first map with a little arrow going to what looks like a small province within a very large country.
Yeah.
Yeah, and some of my questions were kind of around broader scale up, but first I want to open it up to the group and see if there are any questions either in the chat, or anyone, you're welcome to just unmute or raise a virtual hand. Yeah, Dr. Sue, good to see you here.
Good to see you. Thank you so much for that presentation. I was wondering, at the end of a trial, before you've completed analysis, how do you make decisions as to whether to turn off the intervention or continue it?
Such an important question. I wish we could continue because our heart is for us to sustain as long as these are needed components to sustain. But our design was driven by budget. I hate to say that. So we had a budget, we had a proposal, and it's funded. Oh, by the way, this is funded by the UK MRC, Medical Research Council. So we had that design. So we then figure we can only have enough budget to do it for 1 year. We also made the strategic decision of not doing it in too many counties because that will also increase the budget. Our budget was about 500,000 a pound, which is significant for Chinese yuan. So at that time, it's about nearly 1 million yuan, I think. Sorry, nearly 5 million Chinese yuan. So it's significant, but we want to do it well and we want to spend money where we should be for this particular study. So we didn't expand the scope to be too wide. So these are all trade-offs that we got to make. So that's how we made it.
Thank you. Borshika.
Thank you so much. I apologize. I missed a few of the early slides due to a conflict, but really enjoyed listening to your very comprehensive way of applying implementation science methods. And I'm going to ask a question that you are not going to be surprised by. I know that you used the REAM framework, and I was wondering whether you had to make any translations to make this work, or did it all happen at the English language level? And then not just translations, as you are applying REAM, what was your experience applying it in the context of the study where you are conducting it? We are very curious about the applicability across different cultural and geographical areas.
Yeah, we find the re-aim framework to be easy to use. I think this is one advantage of it. We did not use, for example, the IOF framework because we find some of those measures are not easy, as you say, to be adapt to our context. For re-aim, we were able to find specific measures that map out onto those concepts. And we believe it captures the bulk of what we want to study. So for the REAIM, we learned the concepts and say, okay, how does it apply to this particular study and context? So then we collected the data and then did the analyses. So it was pretty smooth. We liked it in using it in our study.
Thank you so much. And did you have to do any translation? So do you now have a Mandarin or different language translation of REAM, or did you function with the English language version?
No, the English language only functioned at the design and the research team level. Then we have everything else in terms of the field work in Chinese.
Okay.
All the field work is in Chinese. And in fact, our local collaborators, all the small team of researchers, we speak English bilingual, but the local collaborators, they only speak Chinese. And
Okay.
yeah, so for the data collectors, the data collectors and assessors, we used the staff from a Center for Disease Control from a neighboring county so that they're not involved in any of the implementation, so they could maintain their objectivity. So we did all the training in Chinese.
Wonderful. Thank you so much. I might follow up with a little bit more detail, but this is so helpful. Thank you.
Thank you. I know you lead the REAIM and PRISM, which is great. Yeah, so I'm learning to use the PRISM framework in some of other studies as well.
Great. Not seeing any other questions right now. I'm going to jump in. So you mentioned issues of policy and leadership likely to be important in scale up.
Yeah.
And I wonder, in your opinion, what are those critical policy and leadership issues, and how might they fit into EPIS framework, for example?
Yeah, in the Chinese context, you know that China has a strong central government as well as very strong local government. By local, I mean it can be the provincial and the county level. The county level in China is the unit where they have a lot of power to make decisions, of course, within the framework of provincial and national policies. So I would say they have the power to scale up to their whole county if they want it. So the policy making at that local level is super important. And policies are driven by the policymakers who are the leaders. So the leaders' influence is so critical. And as is common, maybe it happens more so in China. It's hard to say that there are a lot of turnovers in leadership. I see that as a big barriers for us doing public health work who want to sustain things or scale up things. So they are usually concerned with within their term, with the term that they serve, uh, their political performance is what they care about. So when we speak with them, we need to find out the common languages and say, oh, hey, this is good for your political achievements too. So that's when they click. And when we have this rapport with this leader, and a year or two later, maybe they are promoted or they are moved to a different county. So we need to re-engage. So these are the things we run into. And I think these are the outer context, and some of these are also the bridging factors I'm learning. So I would love to learn more, which is great that I'm here at UCSD learning more, and could back then, as I said, we were doing it by translational research, common sense, and the limited knowledge from implementation science we had. Still learning, which is one thing good about doing research, that we can keep on learning.
I completely agree. And I know some of those turnover issues are common here in the US. In fact, my NIDA grant that we're just wrapping up now, we had a statewide election, new governor, new directors of the different health authorities and commissions. And so it's like selling and reselling and repackaging and
Yes.
trying to figure
And
out what those
yeah,
markers.
and
Go
the
ahead.
leaders, they have different personality and different priorities too. So
Yeah,
yeah.
really. Um, yeah, and I think I've learned from Dr. Sue, who's on the Zoom, the complexities with moving from policy to how the healthcare actually happens, which I really appreciate the nuance, especially in our complicated healthcare systems.
Mm.
Um, yeah,
I've been thinking a lot about that, sort of, if you don't mind me jumping in, because this is kind of a
yeah,
cool conversation about if you have this evidence-based practice and you're not just trying to implement it in health systems, but now you're trying to influence policy, kind of what Dr. Yan just spoke to, you have to understand the perspective of the policymaker, right? And is there
Yeah.
some technology that we can leverage to understand their perspective? I mean that I'm in that space of fertility preservation for cancer, right? So you could see that a policymaker, to make a law about covering that for insurance, they could do it because they themselves are infertile. They could do it because they care about families. They could do it because they're a part of America's MAGA and trying to make America fertile again. So how do we systematically find that and then match the data that we have, the empiric research evidence on why it's important to cover this, to their need? I wish that there was a better way to understand where they were coming from outside of just your personal relationships.
Exactly. I think there are researchers who do this kind of research. I myself has not focused on policy implementation for my own research, but as I get older, as I the next phase of my implementation research, I would love to learn more about what you're saying. I would love to, I know there are literature in there, and if possible, and also learning about loci. I think Professor Aaron's work in loci is highly relevant, even though it's not policy implementation per se. So there are researchers doing that, so we could learn, and I want to devote some of my time in that sphere. But I don't have much to share as now, other than my own experience of these few studies.
Yeah, and I think, I mean, where this discussion is going, it's got a big overlap with political science. And so, we can learn from political science as well, because there are approaches there that can inform trying to understand what drives policy. And yeah, and it's a complex field, because there's, political careerism, there's constituents, the degree to which representatives in either appointed or elected leadership roles prioritize agendas of their communities versus personal agendas. And
Yeah.
I mean, that's just part of it. Then there's how well they communicate and their influence networks as well that make this up. And I worked for a number of years with a mental health advocacy organization in Sacramento that worked on policy design, and they were engaged on a day-to-day level with legislators, helping to draft policy, and then of course so there's a level of engagement with an advocacy organization. Sometimes that happens, sometimes that doesn't happen, and that's part of that bidirectional bridging factors that we talk about. It's not just a policy decision happens and it flows downstream, but there's these influences on policy. And there's, I think, opportunities to understand how we're influencing policymakers. And there's a lot in dissemination science around, packaging evidence, what kinds of evidence, how it's packaged for policymakers. But that's just one piece of it, because
Yeah.
advocacy organizations can bring some clout in changing opinions as well.
I want to follow up this discussion on policy and such to say that it's so idiosyncratic, if I use that term right. It's very context specific, like the differences between Chinese policy context and the US is just huge. So that's why I'm highly interested, which I'm probably 80% confirmed that I will spend some of my sabbatical in the spring in Vietnam, because Vietnam is a country that shares a lot in common with Chinese system, the political system. But of course, we're also very different. So this is one reason I like to spend some time in Vietnam. I saw a great question in the chat from Anisha. So shall I go to that question, Greg?
Yes.
Okay, so it's about the incorporation of simplicity in designing our intervention for sustainability. I could go on and on with this question because we did struggle a lot with this, and it's always a trade-off. I can just start with a few big examples. From the very beginning, when we submitted the proposal to the UK, and it's funded as such, where I had a graph. The top one shows the medical care part, goes from the neurologist to the county specialists and the primary care providers and patients on their medical care. And then I have a bottom, which is the parallel line that goes through this rehabilitation specialists and nurse practitioners, etc., family members to help with their rehabilitation, because these are stroke patients. Many of them are disabled. We did field work for half a year and have experts from Tiantan Hospital, neurologists, have experts from Peking University First Hospital in the rehab department going to the field with us. I quickly then, not so quickly, about 4 or 5 months into it, I figure, no, we can't do both, even though it was funded to do both. Luckily, the UK gave us a lot of freedom. So I dropped half completely in this trial. We had other trials doing rehab by itself. So this is the first simplification, which I'm glad I did. It was a hard decision. I need to say sorry to the collaborator and saying we're not continue in this trial, etc. So first decision, remove the rehab part. And the second example, within the mental care part, we have so many to choose from in terms of the EBPs because the guidelines are comprehensive. So what do? If we do all of that, it's going to be too complex. So after, again, also the field-based research, we decided not to do anything related to diet. And we decided to only focus on, for the patient side, medication adherence, physical activity, for reasons that I'm not going to expand on. And also, it's hard to say whether we made the right decision, but from the results, if you go backward, it looks like we did the right thing to make that choices. But it's a lot of both to understand the needs and to have this co-creation with our participants and stakeholders, but also there is still decision to make. So we made those decisions. That's also very dramatic that we didn't focus on all of the important dimensions. And then in terms of the choice of the implementation strategies, we focused on three. This is the timer. We focused on three, mainly the capacity building, training, and the incentives and the digital technology. There could be more we do, but we decided these would be a good balance to handle. Not too simple, just one, or not too complex.
Yeah, and I think this is really a great example of some of the tough decisions as implementation and effectiveness researchers that we need to make in these trade-offs. And hopefully the research will tell us whether we did it right or righter or not as right as we go forward. So I just want to thank Dr. Yan for this wonderful presentation and your kind of deep thought and deep dive into implementation science. And we're just lucky to have you here visiting at UC San Diego. So,
Thank you so much. Still learning a lot. Thank you, everyone, for coming. Thank you again for organizing it. Thank you.
thank you.
Bye-bye. Have a good day.